we have a group practice, so it's me and my partner, Dr. Lee, and we have 2 associates. So I want to kind of represent what maybe a group practice model may be for the laser, and have some interesting quotes from my associates. They've been using it now for about close to 2 weeks, and we've been using it since November, my partner and I, Dr. Lee. So that gives us, I guess, about 3 months under our belt with the laser, and the associates as well. So I have some interesting quotes from the associates. And she says, "It's like the microscope. Once you use it, you just want to keep always using it. You don't want to stop using the microscope all of a sudden. We can all do root canals with loupes and without a microscope, but it's just so much better." So let's start with some of the cases. This is just a case here I did, number 18. It was partially necrotic, as you can see a bit of a lesion there, and I was pretty happy with the result. It was done with a radial firing tip number 20, size 20, following irrigation protocols as set forth by Charles, and also Biolase. And so there, it was done with clean and shape mode as well as some disinfection mode. Difference there is just that you have a little bit more energy in the disinfection mode, where you might be able to perhaps disrupt some tissues at the apical areas or deltas at the apical areas, those kinds of things. But I felt very confident in its cleaning ability here, and so that's just one case.
Hey, Fernando, can you leave on this case for a second?
Sure.
So if we look at the pre-op here, let me ask you a question here. Is why did this tooth undergo necrosis?
Yeah, it was if you look closely, it was a very, very shallow filling, and it was a slight crack beginning as well on the tooth. So that was the reason for it. A shallow filling that induced a small little crack, and because you would think it's far away from the pulp tissue, but in fact, there was a crack. Can't see it on the PAs here, but there evidently was a small crack that just led to the pulp thorns to necrosis.
And so I think if we look at the pre and the post, we can see the minimal access that you were able to perform, and going in, probably through your consultation and your diagnostic workup there, maybe you saw a crack visible clinically. And the last thing we want to do on those cases is really hog the tooth out, open it up, and further weaken the tooth, taking away more tooth structure. And I mean, this access is 2 millimeters maybe. It's a beautiful access. And the instrumentation, you've got a multiplanar curve there on the mesial root canal system. Now, can you talk about taking the fiber down the mesial canal system, and in the past, would you have probably opened this up more to irrigate to ensure that, and just those kept?
Yeah, correct. I would have at least taken it to like a 25 hand, a rotary file, perhaps. I would have spent a lot of time going back and forth with different files, making sure I established a glide path, and recapitulating back and forth with it. Going with, like, say, a 1504 and then a 2004 and then a 2504, maybe not to length, and then repeating the sequence perhaps. And then again, going back with hand files, 8 and 10s, just a lot of going back and forth with instrumentation. Believe it or not, the radial firing tips never made it quite down to the apex here at all, and they didn't need to. We're taking tips either mid-root or even less than mid-root. And in clean and shape mode, it's able to, once you've established some sort of length or almost length, and you've confirmed you can kind of reach the apex with say an 8 or a 10 file, you can do some coronal flaring minimally, and then just apply the laser energy with clean and shape mode halfway down the root where it's not binding, and just literally do a 2 to 3 or 4 second pull out slowly up coronally, and then you just syringe irrigate, and you can go through a series of these, and you'll be amazed. The files just kind of glide down to length without much going back and forth of instrumentation. and the smoothness of the walls are just to me unprecedented. I never felt smoothness like that within the canal walls as I do now with the laser. It's pretty amazing.
Great, nice case.
Thank you. So we'll go, I guess, to another case here. Here's a similar, I guess, idea. You know, same thing, cracked tooth, number 18. Again, not trying to you know, access too largely here. Obviously, conservation of tooth structure is kind of what we always want to do, really. Why remove more tooth structure than you need? Here's a case as well. It was a partially necrotic, a little bit of a lesion there, number 3. This had a small crack, but it was also had decay and deep filling as well. That you can again see the conservation of tooth structure there in the pericervical area, and just a nice fill. I do feel like that it just can clean so well for you, the laser. Let's go.
Dr. Meza, how is your, go back to that one, how has your instrumentation changed from before incorporation of the laser to now? Are you doing anything different? Are you doing it all the same?
Actually, I'm glad you brought that up, because in this case, if you look closely, I wish I had another angle of it, but there was an MB2 canal. And what's so interesting, and my associates who's only used it about a week or two, about 2 weeks, has confirmed this as well, is sometimes, well, I was taught kind of mostly finish as much as you can or get down to apex on an MB canal, and then perhaps start, you know, working down the MB2 canal. Well, in some cases, the MB2 canal is just so tight, or it's just entering at such an angle mid-root that it's hard to work on, and you require, you know, 6s, 8s, and 10s, and back and forth, and flaring, and all this stuff. Just a lot of back and forth again that I'm not getting. And in this particular case, same with my associate, you kind of, you know, you can introduce an orifice opener, and then literally a 1504 file close to the apex if you want to. You don't have to. And then place the laser in the MB canal mid-root. And as you do that, again, 3 to 5 second pulling out motion, amazingly, you can take the file that was kind of obstructed or couldn't go down quite easily in the MB2 canal. It just goes right to length. It's amazing. So we've had many of those situations where, for some reason, I guess it's connecting somewhere in the laser energy with the micro explosions, is able to disrupt a lot of the collagen or pulpal remnants and sort of clear out the canal space, if you will, including the neighboring MB2 canal. So it is pretty amazing how you don't have to fuss and mess with the MB2 canal for a long period of time. You just sort of clean the MB, place the laser tip at mid-root MB, and then now you've got an 8 file that can just kind of almost reach the apex with almost no effort through the MB2 canal. So,
yeah, you know, several years ago we referred to that, and along the apex too, is kind of doing the endo dance, and, you know, bending files, working them around. And I've kind of been thinking about this for a while. The endo dance no longer requires files. It's using the energy created, the cavitational streaming, which is multisonic streaming from the laser to, you know, gain apical patency to debride MB2 canals. So basically, the endo dance is leaving the natural canal anatomy like it was. So not imparting, you know, much shape or minimal shape to it, and just kind of leaving it alone. But great case.
Thank you. Let me see here. Just to show you again, conservation of tooth structure, both 4 and 5 year had to be, they were irreversible pulpitis. Patient just couldn't bite down on the teeth anymore, just needed both of them. In fact, we started with number 4 originally, but then she had to come back for 5 as well. But anyway, I had some in between shots of the post-op of 4, but I decided just to show you start from finish here. But just again, sort of conservation of tooth structure, what can be done with the laser, and success and patient discomfort is gone, and you just treat a very nicely clean canal. Here's another case as well, long canal, partially necrotic. Again, sort of conservation of tooth structure and the access, being able to reach those apices pretty quickly. That's what's amazing about it. It's just that dance that you just talked about just gets kind of cut in half. And we are also using less files. And what's interesting is my colleagues and also my partner and associates have pretty much brought it down to 3 files. And what's beautiful about it is that you don't necessarily have to have the same 3 files. Everyone's using different file systems. And that's kind of nice, because if you're used to a certain file system, you can kind of bring it down to three of the ones you like the most, or perhaps, well, you want to be, an orifice opener style, 2006, perhaps 1506, 1706, and then potentially a 1504, 2004, or 2504, I think is all you pretty much need. The rest is done by the laser energy and the streaming effects that disrupt the collagen and pulpal tissues, as well as disrupt bacteria and biofilm, not to mention. And then it's more finding, it's not so much putting a cone to length that was dictated by the last file size you used. It's more or less finding a thin enough cone that has that reaches that apical end in somewhat of that almost tug back type feel at the apical end as you coat with sealer. That's kind of what we're finding nowadays, is you're probably just filling it to more of its true anatomy at the apex, and not necessarily opening up to like a 30 or a 35 or a 40, with a file, but allowing the laser energy to clean it to that amount, if that's what if that's what nature, if that's what the canal was to begin with. Again, some other cases that I just showing here: irreversible pulpitis again. Here's another thin case that you could see here, pretty minimal access, and again, you can clean the apical end beautifully with it. I've also had a lot of less potential side-directed pressure type pain that can come about in some of my cases I've had over the years. Of course, I know everybody has is this annoying sort of tapping on the side of teeth. I have honestly experienced much less of this since using the laser. So I owe it to just being able to clean a lot better, more efficiently, including even in some of these much more conservative accesses that we're doing. Again, showing sort of how minimally you can prep, and even in necrotic cases like this. At the very end here, I'll show you a post-op that I have of my limited time using the laser. It's been almost 3 months, but I have a 6-week post-op that I believe is showing some healing, which I'm going to include here at the very end of this presentation. Here's another lesion with a nice lateral puff there. You tend to get these more on necrotic cases, as we would anyways, but I do believe we are cleaning much more, even in vital cases, no question. Another necrotic case through a crown there. Here we get a little bit of these puffs again, necrotic case. This is an interesting one. On the mesial canal, I was placing the laser energy on disinfection mode, which it pretty much meant that it was putting more energy into it, or there's more joules. And so what was interesting about this one was that as I left the tip in the orifice in disinfection mode, after about maybe 10 seconds or so, I saw an eruption of debris come out of the mesiolingual canal. And it was almost like a small worm. It's kind of interesting. Never saw that before. Debris just erupted right out of that canal. So I would have never seen that had it been the laser. And we do see a lot more debris coming out as you irrigate in between the lasing as you incorporate the laser during your instrumentarium and cleaning and shaping as you syringe irrigate as well. So I do see a lot more debris removal. And this is it. This is the last case. This is the 6-week, if you can believe that, post-op. I do believe there's some healing there. I mean, it's almost the same angle. It's not quite exactly the same, but this is an interesting case in that it was a retreatment. And so there was actually, I neglected to show you the pre-op. I guess this, on the left screen is the immediate post-op. And it had a broken file in it. And that's what you see there on the MB canal. That was a separated file. Now, in some cases, you are able to remove the file with the laser energy. In this case, I was not able to. However, I think owing to the ability of the laser to clean so effectively in different and hard to reach areas, the file was left in place. I found the MB2 canal, and to me, it seems like we've got some healing here just in 6 weeks.
Yeah, that looks great. You know, I've had that experience too on separated instruments. I've been able to remove some and other ones, you know, depending on, I think it matters, you know, where it's bound, and the length of the segment as well. The smaller ones seem to come right out. They're larger pieces don't seem to come out as easy, but you know, the fluid dynamics that we're creating with it, I think, is cleaning around it. And I think that's contributing to that rapid healing that you see here. So great case.
Thank you. I expect to see that too. I do expect to see, just based on patient outcomes as we've been calling them afterwards, which we used to do anyways, we are seeing a bit less. I mean, it's not a scientific project or study here, but we are noting a bit less discomfort after treatment. I feel that we're probably going to get faster healing. It'd be very interesting to do 2 or 3 month follow-up with CBCT and really truly get understanding of the volume of the lesion decrease in volume size, and maybe compare even to teeth treated without the laser, just possibly how much faster we can get with the laser energy. So I'm very excited.
That's great. You know, we've got some questions here, but we'll answer a good majority of these here at the end. And I want to ask you one thing here before we turn it over to Dr. King. Dr. Meza, is one specific question. Are you using any type of irrigant while using the laser in the canal other than just water?
Yes, so I go in between with 6% hypochlorite as well as a 0.5% hypochlorite. So we will lase inside the canal with hypochlorite, and I have found it to be no problem. If you feel there's a situation where you may potentially, you know, want to decrease the concentration, I found no issues in using the 0.5% and lasing the tip inside, and then afterwards rinsing it with the 6% solution, as you maybe use your files or maybe hand files or to instrument, and then going back and diluting it again with the 0.5, and then lasing again with the tip. I think that's a valid way to do it if you're concerned about any kind of hypochlorite, but quite honestly, we have not had any issues with the hypochlorite.
I'll show a little protocol and then maybe a study at the end that kind of talks about that. So great cases, Dr. Meza. Thanks for sharing those with us. We'll have some more questions at the end, but Dr. King, let's turn it over to you.